We have a great setup today in terms of the speakers that we have. We have Dr. Arifa Parker, who's going to be talking about screening and triage and her experiences at Tygerberg Academic Hospital in Cape Town, South Africa. Without further ado, I want to introduce Dr. Arifa Parker. She's an infectious disease specialist. She works at Tygerberg Hospital in Cape Town and is also part of the medical sort of teaching staff at Stellenbosch University. So Dr. Parker, I'm going to hand it over to you.
Thank you, Rory. Good afternoon. And thank you to African Federation of Emergency Medicine for inviting me to share our screening experience and mostly the lessons that we learned at Tygerberg Hospital. So for those of you who may not know, Tygerberg Hospital is one of the large public sector referral hospitals in Cape Town, South Africa. It's situated quite close to the airport, and before we had any COVID-19 cases, it was one of the sort of designated hospitals for potential COVID-19 travelers who would arrive at the airport or port house. The drainage area is largely a densely populated area with a large population of vulnerable people. So I will show you what our experience was. So before I go ahead, I'm not going to spend too much time on this slide. Except to say that COVID-19 is caused by the SARS-CoV-2 virus, which is a novel and new coronavirus. So our bodies have not been exposed to this new coronavirus. So in other words, we don't have antibodies to this virus. So a subset of our population, largely the elderly and patients with comorbidities like hypertension, diabetes, and obesity, are actually at risk of severe disease necessitating hospitalization. And a general extrapolation from studies that have been published is that 80% of the population, we obviously expect that to be a bit more because we're not tracking or testing the asymptomatic and oligosymptomatic cases, but generally 80% of patients would have very mild disease, and 20% on average would require admission, of whom about 5% would need critical care. So it's very important when you're setting up a screening area to be able to decide who needs admission and who can actually be discharged. And also when you're setting up a screening area, you have to understand the transmission dynamics of the SARS-CoV-2 virus. So what we do know is that it is spread by droplets. So when a patient coughs, you have generally large to small droplets which can spread within a 1 meter radius. And also, you can also acquire the infection by contact with these infected droplets. There's a lot of chatter about potential airborne spread, but thus far there's been no convincing evidence to say that this virus is transmitted by airborne spread. So airborne basically means that you have much smaller particles and they either remain suspended in air for a longer time period. But I have to say that certain procedures that you need to do for COVID-19 are viewed as aerosolized generating procedures, and these would include procedures such as intubation and also obtaining the nasopharyngeal swab. An appropriate PPE would then have to be worn in that scenario. The virus is actually highly infectious. R naught is said to be around 2 to 2.5, so one person will generally infect just over 2 people. My feeling is that it's probably higher than that based on what I'm seeing at the moment. But your aim of your screening center is actually, or the main aim, is to pick up patients so that you can isolate them, trace the contacts, isolate the contacts, and the main aim is to reduce this R0 to below 1, which is said to then, flatten the curve or end your pandemic. It's obviously a lot easier said than done. So the rationale for screening and triage, if you look at the epidemiological curve, we all know this curve. The aim is to flatten the curve and also to increase the line of the healthcare capacity. But from a screening point of view, your approach to screening will be different at various points within this curve. So in the beginning, if you look at the green arrow, this is the period early on in the outbreak when you either have 0 or very few cases, and you would generally then have stricter criteria for screening because you don't want to screen patients or pick up patients who will test negative anyway. And in our setting, this was largely in the beginning, we tested initially only returning travelers from Wuhan, and then the case definition expanded to the rest of China and Southeast Asia. And as more countries got involved or had cases, we expanded that case definition. So our indications for screening or our case definition had to rapidly change during as the pandemic sort of unfolded. So after travelers, we then expanded our case definition for doing testing to contacts of travelers. And then later on, where we are at the moment, we are currently in the phase of community spread, where we have lots of cases. So our case definition has now expanded to include testing for all patients who have a respiratory illness, regardless of travel or contact history. Asymptomatic cases are still a problem because our system doesn't have capacity to test. But I can say from our experience, we have tested cases and we have had positives. So we are definitely missing asymptomatic cases. Just on the dotted line, if I can go back, very important is while we're trying to flatten the curve is to increase your healthcare capacity, which is possible. And how we did that at Tygerberg was that in the beginning, our plan was to over-prepare for the COVID response, and with the understanding that even if we were over-prepared, it would probably still not be enough. So we had buy-in from management and provincial and national health departments to suspend elective procedures. And this was also part of the strategies to improve or limit social distancing with a view to flatten the curve, but it also gave our hospital and other hospitals a chance to roll out staff training, educating staff so that we could expand the staffing component of our healthcare response, obtain equipment, and also PPE. So we found the main things that we focused on was to increase bed space, obtain equipment that we needed, and locate staff within the hospital that could cross-cover different areas. Fortunately, we had buy-in from our other departments within the hospital, and we view our response as a whole hospital response, not just sort of an internal medicine or emergency medicine response at present. So this was from a WHO guideline published in March, and it basically shows the 4 different transmission scenarios. In our country, we are in the 4th scenario. And I put this here just to say that it is expected that at some point, we are seeing this in our country at the moment, at some point your lab capacity will be overwhelmed. There will come a point where you have too many patients to do testing on, and we have guidance for this. You can actually focus testing on inpatients, patients who have severe risk factors for severe disease, healthcare workers, and specific high-risk settings. The screening process has to take IPC principles into account. So I will show some pictures later on. This will encompass, preventing infections or strategies to prevent infections to healthcare workers working in the screening area, as well as fellow patients who are attending the screening unit. It's important to have a process where patients are streamed into a single secure point of entry. At our hospital, the meet and greet is done by a security guard who is wearing a mask, and there is adequate distancing. The patient is supplied with the mask. And actually, at this point in the outbreak, all our patients are actually coming in with masks. So we do give alcohol so that the patients perform hand hygiene. And then we use a pre-screening checklist to do triage and risk assessment. And that is how our screening process unfolds. In this process, it's very important to document the correct phone numbers and emails, because we need this for results tracking and informing the patients if they do go home. And then obviously the testing component, I'll show some images later. Very important that all staff must be trained. So prior to setting up, and actually in parallel with setting up systems, you have to ensure that staff are well informed about how the virus transmits, and also how to use PPE appropriately and what PPE to use for specific scenarios. Staff have to understand the risks and how to minimize risks of transmission. So at our hospital, we very early on in the outbreak, before we had cases, this is Prof. Helena Rabi from Pediatric Infectious Diseases, and she assisted us and did quite a few videos on PPE, and also a video to teach staff on how to collect SARS-CoV-2 specimen appropriately. So before staff came to work in the screening unit, they had to watch the videos, they had to know how to use PPE, they would observe, and then they would do under supervision. We held regular meetings, and much of our IPC, or actually everything, is based, we decided to stick to local guidelines. So whatever we practice is based on what is in our provincial and national guidelines, and we don't deviate from that, because we feel that deviation also creates confusion. And we are quite happy with the guidelines we do have at present. So the location of your area needs to be strategic. It should be very close to the hospital entrance, so that patients who potentially have COVID don't wander around the hospital and potentially infect other staff or patients. So it's important that there is very clear signage We also learned lessons when it came to signage. So you can see how the different one on the top right, which was a very dark blue one, wasn't easily visible. People ignored it, and we ran out of ink. So we changed it to the white one, which is much more easily seen when patients do come into the hospital. So you have to direct patients to the correct entrance and also away from other entrances. So when patients come to the screening area, we do a very quick triage, which is basically based on observation. So we assess if a patient looks unwell, we count the respiratory rate, and we use the SATs to get the heart rate, because you can be caught out by a patient that looks well and actually has silent hypoxia. But at the center, at the actual screening area, we use a minimal contact approach, and then patients who are triaged as more than mild disease would then be admitted and would get a full examination. And the criteria we used is based on the national guidelines. So tachypnea, we want the patient to have a normal mental state if they're going home. They must be fully mobile, normal SATs. We don't routinely do temperatures on everyone, but we also use dependent on how busy we are. But we also ask about a history of fever. And then we do on the SATs probe get an indication of the heart rate. Very important in the screening area is that the patients need to be distant. So we have signs up. Sometimes we use a queue marshal who maintains distancing between patients. We've got floor stamps, but we find that is overlooked a lot. So we still have to sort of enforce it. We do have challenges when it comes to distancing patients, especially if we get large clusters from a specific, we get a lot of employees potentially, where there's a positive case and we test a company. It's very hard to distance that group. So that's sort of one of our challenges. And then on the right, I show some chairs. So initially, when phoning out a negative result, the patient actually complained to me and she said that, we weren't enforcing contact limiting, for example, when she visited the center, the patients were moving along on chairs, which is obviously an avenue for transmission. So we changed our approach. So when a patient enters, they get a chair and they use the same chair throughout the screening and testing and discharge process. When they are done and they leave the chair upside down, and then we clean the chairs at regular intervals throughout the day. And you can see one of our administrative staff actually volunteering to clean chairs when we were short on cleaners. So this is an example of what we use for risk assessment. So the first one's lots of words. So this was, in Jan and Feb when we would just have isolated patients coming through. We had one isolation room in the emergency unit. And then we started getting more patients, and then we expanded it to 2 isolation rooms, and then we realized, no, this is not going to work. And we actually set up a separate screening area where we could see more patients and sort of streamline the patients away from the normal triage and emergency unit of the hospital. So it's a completely separate area. And then just some images just to show how our screening tool evolved with time. So the one on the right basically still looks for respiratory symptoms and travel history or contact history. And later on, it evolved to including all patients with respiratory illness, and then later on we added symptoms like loss of smell, loss of taste, etc. Once a patient then met criteria for testing, more extensive history would then be done in terms of other symptoms of potential coronavirus like diarrhea, etc. This is a slide just to show where we do our swabs. It's very important that the sampling, it's viewed as an aerosol generating procedure. This is obviously still controversial, but in our guidelines, we do view this as such. So we use a well-ventilated area. So not what's not in the picture on the left is we actually had an extraction fan installed into that room with 60 air changes per hour, which allows for rapid reuse of that room. There are actually two rooms, so one on the opposite side. It's important that that room has no clutter, so the only thing in the room comes in with the patient, which is the chair. We take the samples inside, and the samples are labeled beforehand. And generally, we have one person doing sampling and would take swabs of multiple patients. And we have adopted a PPE preservation strategy. So even though the guidelines say N95s are single use for this procedure, we do extend the use of our N95 masks. And as long as the gown hasn't touched anything, we use the same gown or change aprons in between patients. We definitely change gloves and perform hand hygiene between patients, and we use a buddy system where there is always somebody just to make sure that the IPC procedures are upheld to minimize risk to patients and subsequent patients and also staff. And they also assist with baggage of the sampling of the samples, etc. We have gotten very busy. Our 2 rooms were not sufficient, and then we utilize natural ventilation and we set up testing centers outside. So that's obviously a very viable option to doing samples. We have experimented with drive-through testing. It works very, very well, and I would recommend it if you have a nice system in place. We could only do this if it was pre-arranged with us beforehand, so that we have the folders, etc. beforehand, so that the process would be quick. One hang-up with our system is actually opening up folders for the patients, and how we address that is that if we know a patient is coming, we send them a link where they can insert their demographic data, and it goes directly to our clerk, who then opens up a folder. And we have often also called the patients to take some of the history beforehand, and that sort of streamlines the process. So the screening process doesn't end with the test. The patient does need some education, and what we use are patient education leaflets. And we also have a video on self-isolation with a link on the letter that we give to the patient, or we also can WhatsApp this to the patient or email it to the patient. So we've got specific discharge letters for different risk categories. So if a patient is asymptomatic, unfortunately, we can't test them because of limited capacity, and we do then advise the patients to self-quarantine, and we advise them, we use safety netting by advising them to contact us if they do develop symptoms, and if they do develop symptoms, we do do a test. This process is obviously different for healthcare workers. And then for patients who we really suspect has coronavirus, we give them information on how to isolate efficiently or self-isolate efficiently. If a patient is unable to self-isolate, we admit them and we arrange a sponsored self-isolation facility in conjunction with our emergency medicine disaster medicine unit. What was a key component of our response was that we used role modeling. We try to always have senior staff working on the floor, and in the yellow gown you can see the head of our nephrology unit who came to volunteer his time at the screening area, and then on the right is our IPC Sister Abrahams, Abu Maulana, one of our internal medicine consultants, and Professor Eliana Rabi, who was also assisting to screen and see patients. So our sort of motto is that we try to be present as one team. We're all in this together. It's one fight, and we use a sort of a team approach. In addition to all of what I've said before, you do need support systems and certain supply chain essentials. You do need admin clerk support, IT equipment. Your cleaning staff are of utmost importance because the place, the center will need to be cleaned regularly. And you need equipment for cleaning. Security buy-in, waste management is very essential. You need to make sure that you have your stationery and that it doesn't run out, that educational material on hand, enough PPE and hand hygiene supplies need to be available, etc. I included this slide just in case, as a reminder that if your system is overwhelmed, that there are strategies that one can use to overcome this. For example, if you have a mild case with no risk factors and you don't have capacity for testing and you want to prioritize it for potential inpatients or ICU cases, you can register it as a suspected case and do home isolation, for as an example. We do strongly recommend that healthcare workers are tested and patients who are admitted are tested. We had some more lessons that we have learned throughout this process. COVID is a new disease. We don't know a lot about COVID, and there are no COVID experts, so we need to be humble. And from the start, I've realized that you need to be flexible. You adapt your process as you learn something new. And one example for us as infectious diseases and IPC specialists, we're always saying public does not need to use masks, and now we had to do a full 360 and say masks for. Teamwork on multiple levels is very essential, and it's important to be a team player. Try to be as far as ahead of the curve, anticipate what's going to happen next by following all the information around you and learning about what's happened in other countries. No country is necessarily unique, and what's happening elsewhere might also be happening in your country, so you can actually anticipate what's going to happen next. Very important is that staff is protected, adequate PPE is available, and very important to make sure that staff know how to use PPE. You can wear the best PPE in the world, but if you don't know how to use it or doff it correctly, or even don it correctly, you may be placing yourself at risk. Staff fears need to be addressed as soon as they arrive, and this is usually with information. It's very important that the screening area has recreation and rest rooms for staff, because it does get exhausting. And then just to remember that outbreaks of COVID can happen within the workplace, so you won't necessarily just get it from patients, but you can get it from your colleagues. You have to practice hand hygiene, wear your masks, practice social distancing, and adequate cough etiquette. This is just some of the team at Tygerberg. The picture on the top is from a dummy run, which happened before we had a single case presenting. And that was a dummy case who then came from the airport, was transported via EMS to our hospital, and we used that to test our systems. And in the picture is medical management, the ward nurses, IPC nurses, our infectious diseases registrar, and emergency medicine and disaster medicine. And we learned a lot of lessons from that dummy run. And I do advise, if you don't have lots of cases, that you test your system so that you can fix any sort of leaks or problems you might have, and just other pictures of our team. Thank you. I encourage you to read our article that's published in the current version of the South African Medical Journal.
Thank you so much, Dr. Parker. So we're now going to move into the Q&A section. So we had a couple of questions come through during your presentation. The first one is, if the cases are mild and they're sent home, what is the danger of spread and how do you manage that danger?
So if the cases are mild and they are sent home, there obviously is risk of spreading. So it's very important to inform and educate the patient on how to self-isolate. So we advise patients that they need to be in a single room. If possible, if there was an ensuite, if they don't have an ensuite, we advise them on how to use the toilet appropriately. We supply the patient with masks. We ask them to remain within the room, and we also give them advice on how to clean the area using simple household detergents which are effective against SARS-CoV-2. We do say that they can sit in the garden, for example, and then we also have contact tracing teams who would then assess all contacts within the house or outside of the house. It does become difficult if the patient has an elderly contact that's living within the house, and then we ask the patient if they can find alternative accommodation. If not, then we do give them the option of being admitted to a self-isolation facility. We've had experiences where patients do say that they're going to self-isolate. They do say they understand, and when we phone the patient back, very isolated incidents, but you must be prepared that some patients might not listen, and maybe that's our fault. Maybe we didn't communicate well enough, but I've had a patient who then went to work the next day, and then we had to call her to come back. So slip-ups will happen. What's been very helpful with us is sending the WhatsApp video, which explains how to self-isolate effectively to our patients. And I've had very good feedback in the patients that I have sent it to.
Awesome. That's a great suggestion. I think we've all seen the power of WhatsApp and social media in keeping people connected and giving them resources. The next question we have is, when it comes to screening, the different features for possible diagnoses, are those applicable to children as well, or is that just for adults?
Okay. Yeah. So what I was saying is that disclaimer, I'm not a pediatrician, but the screening protocols that we used was in conjunction with myself and our pediatric infectious diseases specialist. So we use the same protocol for adults and pediatrics.
Great, thank you. I think the next question we have is about staff infection rates for medical staff, because screening obviously exposes medical staff as well as treatment of patients. Have you found the infection rate amongst your staff to be quite high? How has that been? How have you been able to manage it?
Yeah, we are seeing, with the widespread community outbreak, we are seeing increased numbers of staff infections. Interestingly, actually all of our doctors that were tested in our sort of COVID high-risk areas have tested negative, but we are picking up infections in the sort of COVID low-risk areas, and initially largely because there was people were not wearing masks or doing hand hygiene. So we've tried to sort of rapidly roll out educational messages, and we've sort of implemented from IPC. They've implemented sort of a staff message of the day, with a little message that goes out every day to educate staff. What we found is, even though we've been encouraging social distancing and PPE with patients, we weren't sort of focusing on staff and staff recreational areas, and so we've sort of tried to educate about sort of IPC measures that you have to take with colleagues. So you can get COVID from colleagues. And then a setback in our setting is that a lot of our staff and nursing staff require transport home and taxis, etc. So, and we find that also may be high risk for acquiring COVID from colleagues. So we are seeing clusters as well related to transport.
And on a similar note, when it comes to how the screening happens, is the screening service offered to all patients attending Merck Hospital, or is this a unique patient pathway for patients who self-refer for COVID-19?
So we have, we've got two different pathways. So we've got the sort of COVID screening area for patients who think they have COVID or referred as having suspected COVID. So screening happens at that site. We've got a separate system where staff are screened. So all staff were required to submit a risk assessment, and staff are required to do it's actually twice daily symptom checks. And we do this on a buddy system, and this needs to be reported to the line manager daily. And we encourage that staff who have symptoms do not go to work, and we do test all staff. And then we have a separate screening area for other patients who come to hospital for other visits. So basically everyone who enters the hospital gets a symptom screen for COVID. With this, we'll probably pick up most cases, because most cases will be respiratory, but we have missed isolated patients who have presented differently. So one patient that springs to mind is somebody who presented with seizures, denied respiratory symptoms, but the chest x-ray was actually quite suggestive of COVID, and the patient's SATs were low. So it's very important that in addition to the symptom screen, that we ensure that we check the chest x-rays and the SATs of patients.
Great, thank you. And then just one last question before we move on to Dr. Sikuvi's presentation. How is the communication with a family of a COVID positive patient?
The communication with the family Do you mean in terms of the patient and the family, or healthcare workers and the family?
I'm not sure. Could the attendee who submitted the question possibly specify in the Q&A, and then we can address it at the end? So the clarification we're looking for is it the family of COVID positive?
Maybe I'll just answer both. Okay, so we interact with the patient. The patient supplies us with an address, employer details, and a contact list, and we submit this to our public health colleagues, who would then contact the relevant people. And in terms of the patient contact with family, we unfortunately don't allow visitors to the hospital because of the risk of transmission. But special, if it's arranged and it's a special circumstance, we can, make any exceptions where adequate PPE, for example, is worn. What I found with patients that I've treated is that if patients use their phones, that it's also a nice way or a surrogate to keep in touch with family. So we're actually exploring options where we can actually obtain phones and Wi-Fi so that patients can keep in touch with their families.
Great, thank you so much. So this is the end of our Q&A session for Dr. Parker. Thank you so much for such an informative presentation. We're really happy to have had you present. And for anyone who is looking for more information about Dr. Parker's work in particular in Tygerberg Hospital, there's a really fantastic article by Health 24 that we've shared in our newsletter. Definitely go check that out.